Thank you, Susan. I think there's been a lot of changes, as you've heard already, about our curriculum across the United States and throughout the world. And I think one of the biggest changes that has occurred has really occurred within the last 10 to 15 years. And I'm going to give you a brief history of medical education. And I think nothing centers us more than this quote. It's much more important to know what sort of a patient has a disease than what sort of disease a patient has. And I think it's a reminder about where our focus has to be when we take care of patients. This was by Sir William Osler. It was in the early part of this century. So when we look at the history of medical education, prior to 1920, there really was no set standard of medical education. It was purely apprenticeship. Okay? There was one school that served as a model, and that was Johns Hopkins. Much because William Osler was there serving as one of their faculty members. He really defined how we create medical education. In 1910, Abraham Flexner did a report of medical education across the United States and basically the woe state that it was in. There were no expectations you could have of a physician. There was no standard that you could be assured of. But once again, Hopkins tended to be that model. So in 1920, most schools had changed, really fitting in with that Hopkins model, that model that was described by William Osler. And William Osler was famous for his emphasis on the patient and their presentation. He wrote numerous case studies and case series where he described diseases for the first time, advanced what we knew about them. This really started scientific investigation, right, within the medical world. Now, in the 1950s, things changed, right? 1953, DNA was discovered, right? Many of us remember penicillin in 1940, but we forget that during World War II, it was really restricted only to the military, and we grew penicillin off moldy cantaloupe. It's kind of sad to think, but that is what changed. Right? It wasn't until 1957 that we figured out how to synthesize penicillin. So with all of those advantages, in 1960, we really branched off in this new age of medicine, genetic molecular medicine. And when you consider the era between 1960 and 2000, in that 40-year period, innumerable discoveries were made. Right? We had a huge emphasis on laboratory, on imaging. We discovered CAT scans, MRIs, right? We just started having randomized controlled trials for the first time, right? Those are those trials that actually define whether a medication is actually effective, right? Let's compare it to placebo. Let's compare it to another medicine. Before then, much of it was guesswork. Much of it was based on anecdote. Now, despite all those advantages, by the 1990s, we were in a place that we were the most technologically sophisticated medical system in the world. But if you talk to patients, what would they say about their medical care? Well, honestly, if you looked throughout the world, we would be about the middle, right? People were not overly impressed with their care. We're having more and more reports out about the errors that occurred in medical care. People didn't have the confidence in the most technologically advanced system in the world. So we changed things, right? And I would say around 2000 is when we started focusing on the comprehensive patient-centered physician. It's not enough just to know all of your medical knowledge, right? You have to be able to assess that knowledge that is coming out, what we call evidence-based medicine. Read those new studies, read those new articles, know what to do with them, know how to interpret them, know what information you should change your practice on, and what information you should wait on. Medicine is no longer a single physician sport, right? We're in teams. We have to emphasize team-based care. I mentioned medical errors. We have to focus on patient safety. How can we make sure that the care we provide is the safest for our patients, that we're providing the highest standard of care? And we have to put the emphasis back on patients. We have to emphasize the communication and empathy that defines what a physician is. As Chipper mentioned, worthy to serve the suffering. What most patients want is a little bit of our time, a little bit of our communication skills, and a little bit of our empathy. So how can we do that? So, as Dr. Smythe mentioned, there's been this tremendous increase in medical knowledge. So these are all estimates, but this is kind of doubling time, okay? And this is how our medical knowledge has grown. So if you consider the first half of the 20th century, it would take 150 years to double your medical knowledge. If you consider the period between 1950 and 1980, it would take about 50 years to double your medical knowledge. Between 1980 and 2010, 7 years. So since I've graduated medical school, there's probably been a 4-fold increase in our medical knowledge. So what's it today? 3.5 years. That means once you've completed medical school, we'll have known twice as much. Well, obviously, we can't keep up with that pace, right? There is no way to know everything. And that is what makes all of these other competencies, all of these other features important. You're never going to have all the answers, but we want to train you to make sure that you can seek out the answers, you can interpret what you find, and you can apply it back to the patient and explain it to them. Explain to them why you're making the decisions that you are. So William Osler also said, "He who studies medicine without books sails an uncharted sea, but he who studies medicine without patience does not go to sea at all." And this is what we have tried to do with our medical education. You know, traditionally you had 2 years of book work and then 2 years where you saw patients, right? Well, there is a great reason why we need to blend those, okay? We have to keep the patient centered whenever we think about our learning our medical knowledge, okay? So our patient-centered education at UK is built on a hybrid curriculum, okay? What that means is we begin with the kind of essential principles of core knowledge. What are those things that you absolutely have to know? And then we work our way through an organ system approach, okay? You probably have visited schools where they go strictly on an organ system approach. And we decided against that because if you start out with the heart, the brain, the kidney, you don't know anything about anything else in the body, right? And as we know, all of our systems are really interconnected. So we want to start with those principles of core knowledge and then go out into an organ system approach. And the reason for the organ system is so we can provide an intensive, concentrated exposure to each area, okay? Focusing on integrative thinking, right? Because once again, our focus has to be what is the medical knowledge we need to take care of patients? What are those things that we can do to improve patient care? So once again, traditionally, you would go through school and maybe do an anatomy class where you'd learn the structure of the heart. Then you do a physiology class where you'd learn some functions of the heart. Then you do a pathology class showing what could go wrong with the heart. Then you use a pharmacology class showing what you could do to treat what was going on with the heart. But that really breaks everything up, right? And it gives you different focuses. It doesn't integrate. It doesn't let you see how the anatomy, the structure, the physiology, the function integrate into disease. In this way, we can really emphasize patient presentations and management. What is that core knowledge that's going to determine how we treat patients? So with that in mind, all of our courses are directed by PhD and MD faculty. Every class has a basic scientist who knows that core foundational knowledge, but also a physician who can apply it back to the patient. Another concept that we have been one of the first schools to embrace is something we call Entrustable professional activities. Right? Now those just sound like fancy words, but really what it is what are the fundamental activities of the physician? Now one of the reasons why we embrace this is we want to make sure that all of our students have the skills that they need in the end. So we're going to ensure that you have competency in all of these activities, and we're going to build upon them each year. So before you even enter the clerkships, we're going to make sure that you can obtain a complete history and appraise a research article for validity, importance, applicability. When you begin your third year and you're seeing patients out on the wards, you'll be able to interpret EKGs, provide accurate and complete documentation of hospital admissions, and a whole host of others. By the time you graduate in your fourth year, you're going to be able to dictate, write, and enter safe and appropriate orders. You can recognize a decompensating patient, initiate urgent treatment, and seek help. We are taking this on as something we're going to ensure that all of our students are able to do. We've got a list of 50 of these. These are just some examples, but we want to make sure that all of our students have these skills. Okay. So I'm going to run through the curriculum really quick. You've probably seen these slides before. This is our first year, though, and this is part of that hybrid approach. You can see we start with anatomy. You know, we think there's a huge reason why you just need to understand the human body, right? And therefore it forms that basis so that you can go through all the other organ systems. Get a foundation in biochemistry and genetics. Make sure you understand the foundations of much of disease. And then foundations of infection, disease, and therapeutics. Make sure you understand the basics of microbiology, pathology, pathologic processes, why we choose certain drugs, those governing principles. And then we start into the organ systems. We start out with neurosciences and then go into behavioral basis of medicine or psychiatry course. Now throughout this first year though, every afternoon is dedicated to Introduction to Clinical Medicine. Now that is not every day, but we have those afternoons set aside in order for you to do various activities. Okay. These will be more intermittent, but you will work out in anatomy, you will be doing physical examination. Checking that stethoscope out for the first time, laying it on the chest, understanding why we do the things that we do when we examine the body. We'll work on interviewing and communication skills, the foundation of ethical decision making. You'll have longitudinal clinical assignments where you will be in physician offices working with them throughout your first year. You know, and I think some of the most rewarding statements that I hear from students is, wow, that stuff I'm learning really is important, right? Because sometimes we can lose sight of that, right? How does this interact with what we're doing? And then you see it in the physician's offices and it all rings home. Second year is a little bit busier, but as you can see as you go across, these are all organ systems. So we'll once again continue through each and every organ system with that integrative approach, okay? By the end of the year, we'll hit our multi-system and integrative course, which Chipper Griffith directs. And this is really the culminating course, right? We've gone through all of these systems, but now let's put all this information back together. You know, unfortunately, when a patient comes in and says, I'm short of breath, they don't say I'm short of breath because of my heart. They say I'm short of breath. Right? So we need to be able to think broadly. We need to think, okay, are they short of breath because of a lung problem, a muscle problem, a nerve problem, a heart problem? How can we sort through all of that? And how can we integrate that knowledge after all? Honestly, it's a great preparation for both third year and for that step exam. Right? That medical licensure exam. And then throughout second year, we have our Introduction to Clinical Medicine 2 course, where you'll be continuing to work on those core skills, those advanced physical examination skills, working on your clinical reasoning and decision making, medical documentation, oral presentations. How can I make sure that I'm prepared to work with patients on the wards and in the clinics in my third year? Third year, we basically go through all of our core rotations, okay? Working intimately with the physicians and residents on all of those services, learning all of those skills. And then fourth year is much more of a honing your skills year, right? So with our acting internships, you will have the experience of what residency is like. With your electives, you'll be able to hone those skills that you haven't developed or explore new areas. And then with our ACPA and intern prep courses, we're going to make sure that you're prepared for internship. We're going to finalize those skills that you really need to be successful as a physician. So in the end, these are our competencies. This is what we want all of our students to achieve by the end. And we're going to work on these every single year. We're going to build on these, right? And oftentimes we just have a tendency to emphasize number one, treat health problems, right? But we've got to be able to apply foundational science. We've got to be able to take the research that's coming out and apply it back to our patients. We've got to be able to evaluate our own performances. We have to make sure that we develop and encourage appropriate relationships with everyone. Function effectively in teams, right? And so in the end, these are our goals. So the last thing I'll say is, I have no idea what the future will bring, but I will tell you that we are constantly working on improving our education. And for me, that is what makes this job exciting. We will never be done. We will never achieve perfection, but we always have to strive towards it. So already our curriculum committee is looking at things that we can do to improve, right? Tweaks that we can make, changes that we can make that'll make your education even better. As you'll hear from Brian Higgins and Brian Atkins, we are looking at new technologies. We're looking at new ways of teaching. How can we make this better? Because in the end, I think that is what we owe all of you, and that is what we owe our state. As Benjamin Franklin said, without continual growth and progress, such words as improvement, achievement, and success have no meaning. And ultimately, our goal is to make you as prepared as possible, to make you the best physicians that you can be. Because in the end, that is how we're going to make a change for the health of our nation. Thank you. Next, I'd like to introduce Brian Higgins. Brian Higgins is new to our medical institution. He actually joined us over the summer from the Medical College of Georgia. He has a PhD in microbiology, and I think in many ways, he is the personification of much of what we're doing here, much of what we're trying to emphasize here, which is how can we get the best education possible for our students. So with that, I'll turn it over to Brian.